thank you on behalf of the International Society for Quality of Life Studies for joining this webinar titled The Wellbeing Loss of Health Inequality with Ada Ferrer-i-Carbonell. Moltes gràcies, Ada. Bona tarda des de Barcelona. And Ada Ferrer-i-Carbonell is an economist and researcher at the Institute of Economic Analysis of the CSIC, an affiliated professor at the Barcelona School of Economics. She is coordinator of the CSIC Global Society area, and her main research focuses on the measurement and analysis of well-being through subjective questions on satisfaction and applications to economic outcomes, such as health, devolution, and inequality. It's a big pleasure and honor to have you, Ada. Thank you very much for accepting coming to ISQOLS again in this webinar. So, Ada, thank you very much again, and the floor is yours.
Thank you very much, Roger. Thank you very much, everyone, for attending, and thank you very much for the opportunity to present and your willingness to listen to me. So I'm going to start presenting because it's a very short presentation, so so we don't have much time to lose with other things. Everybody can see my screen, I take it?
Yes, it's perfect, Ada. Thank you.
Okay.
Yeah.
So
great.
Thank you really very much. I'm super happy to be here, so we'll start. So this paper is about measuring the well-being loss of health inequality. What we basically do in the paper is we use a well-being methodology that is familiar to all of you who are here, so it doesn't need a lot of introduction, as in contrast to when I present in other audiences, to estimate the population well-being lost from health inequality. So basically, we try to retrieve from data the inequality aversion parameter, and I'll go into more details with it by exploiting the longitudinal variation on inequality that individuals face. So basically, the aim is to estimate the sacrifice that society is willing to accept to achieve a more egalitarian distribution, in this case of health inequality. Why do we think this is relevant? Well, we do know from the literature that the context where the individuals live is very important for their life satisfaction and their well-being. We know that there are papers that look at things such as poverty rate, unemployment rate, inequality, the quality of the institutions, living in democracy, etc., and how all these variables are important for individuals' well-being and therefore should be important for public economics and from any policy making. That's one thing, but also to get even more focus, we know, for example, that policymakers implement a lot of health problems, and these health problems have a cost. And besides the direct costs, direct benefits that one can have from this, for example, imagine that government introduces screening for breast cancer or for colon cancer to population older than 50. This has a cost to the government, but the benefit goes beyond the benefit of those that benefit from the screen directly. But also, if this reduces, for example, health inequality through providing access to screening to individuals that are 50 plus and otherwise, because of economic reasons, for example, will not have access to it, this intervention reduces health inequality. And this health inequality reduction is not usually or never probably taking into account when doing the cost-benefit analysis of program interventions. So some program interventions may have benefits that go beyond the direct effects on health and affect all the rest of the population by living in less unequal societies. So basically, what we want to do is we want to estimate the importance of health inequality. And we think that on top of what I have already said, this also may be a determinant of individuals' social and political choices. We know, for example, that in times of high unemployment rate, the probability that individuals vote the incumbent is smaller than in times of low unemployment rate. In times of economic crisis, if there is more inequality, more poverty, people may take voting decisions that have a large impact in society as a whole, and therefore we also think that this is important. Now, this is about health inequality, and as I say, there are papers on unemployment, on income inequality, etc. And in fact, there is quite large substantial literature on why individuals care about income inequality. And I will briefly discuss this to the extent that this is also very relevant for health inequality. So basically, and I'll be quick on this, but it's important to just summarize it. Individuals dislike income inequality for several reasons. And some of the reasons that have been put forward, or the main reasons that have been put forward, are in this slide. So one is all the negative externalities that the income inequality has for the whole society. High inequality is usually linked to, for example, more social instability, higher crime rates, etc. So that has a negative externality on those, even if they are on the top of the income distribution. And also more inequality has larger social expenditures for governments, higher fiscal burden, etc. So that would be negative externalities that would impact all the population. Income inequality, for example, is also having an impact on things like access to education or access to networks. And that means that if there is more income inequality, there is a portion of the society that might not have access to the networks and to education system, and therefore we lose potential human capital, and therefore we lose economic growth. Inequality also erodes social capital. People living in high inequality regions show less trust to government, show less trust to others, and that also has an impact on policy effectiveness. There is another reason that has also sometimes been put forward, that is genuine egalitarianism. Maybe there are people who just want that everybody is the same, regardless of anything, no matter what. And that it's what it's called genuine, in the sense that it's pure equality, preferences for equality, regardless of the situation. While then there is also people that are having preferences for redistribution, or they might dislike inequality only as long as this one is related to their feelings of fairness. For example, if they consider that we live in a society that it's not meritocratic, or there are no equal opportunities. Some people, depending on your background, if you are born, for example, in an economic background that is poorer, you have less opportunities to access education and therefore to progress through the income distribution. If this is the case, if people think that they live in a society in which the income distribution that we see is not the outcome only of effort, but also of circumstances, past circumstances, place where you are born, etc., then people will dislike inequality more, not only because of a genuine egalitarianism, I can never say this word, but just because they feel that income distribution is the outcome of an unfair process. And then finally, another of the main reasons that has been put forward is risk aversion. If individuals are risk averse, under the veil of ignorance, they want an income distribution that is more equal, so to avoid the risk to fall on the bottom of the income distribution. Even if now you are situated in a place in the income distribution that is not at the bottom, if you are very risk averse, you will want to avoid income distribution in your country that makes you end there. Okay, so that would be more or less what the literature has been put forward on why individuals dislike income inequality. There is also some reasons why one would think that some individuals or some societies in certain periods of time may be in favor of income inequality. For example, one reason is that if you feel you live in a society that is fair and that everybody who makes an effort has access to higher income, then you think, okay, the outcome, the income distribution of my country is meritorial. People have the income of the people relates to the effort they put, then inequality is fair from their perspective, and therefore there is no reason why they should not like inequality. Or for example, if richer individuals like to be richer than the rest of the population, if we have relative concerns and we feel that we prefer to be at the top of the redistribution because that makes us feel relatively better, then we need someone to be in the bottom. So it could be that individuals with very strong relative concerns like inequality so that they can end up at the top of the distribution. And then there is the pure economic growth argument that in the same way that if there is inequality, we may have suboptimal human allocation of capital. It's also true that richer individuals have a higher propensity to save, and therefore sometimes inequality leads to higher savings for those in the top of the distribution, and therefore higher economic growth. We know also that income causally determines, the other way around, that health satisfaction causally determines income. So there is a correlation between inequality and health. Individuals that are healthier tend to be richer, and richer individuals tend to be healthier. However, we know from the literature that a large part of this correlation really runs from being healthy to higher income. So those individuals that are born healthier have a higher probability to end up in the top of the income distribution and access a higher income. Therefore, health is a determinant of income, and thus also health inequality leads to higher income inequality. So there is reasons to think that individuals not only dislike income inequality, but they also will dislike health inequality for many of the same reasons, and also from direct reasons. For example, feelings of fairness or a risk aversion applies both to income and also to health. But what makes health so specific? What is different in health inequality that it's not the same as income inequality? First of all, there is some arguments made in the literature that individuals believe that health is beyond individuals' control, or at least that health is beyond individuals' control to a larger extent than income. So faced with an income distribution and a health distribution, which look similar, most individuals will think that the health distribution is more a matter of luck, of genetic makeup, or of simply being lucky in these circumstances. So there is a large set of literature that I will argue that if fairness is important to determine inequality aversion, then the health for us, the health inequality, we perceive that individuals will perceive, sorry, I have made a mix-up. Let me start again. So if individuals believe that health is more a matter of circumstances, of genetic makeup, of luck than income, we would also expect that individuals think that inequality on health is illegitimate, or it is more illegitimate than income inequality. So this is more specific to health is this both for health and income, but it's true that we would expect from the literature, we expect that individuals dislike health inequality more than income inequality because they perceive that it's due to circumstances and not as much to effort. Also, there is a second characteristic that makes health inequality very different than income inequality, and that is that we cannot transfer health across individuals. So it is true that we can redistribute health to a certain extent. We can make access to health more universal. We can protect individuals that live in polluted areas so that the pollution contact is reduced. We can introduce health programs, etc. So there are a lot of things that we can make to have a more equal redistribution of health, in the sense that we give access to health to those individuals that have lower health. Nevertheless, what we cannot do is to transfer health from one to another person, which is something we can do with income. So we have that income is transferable and health is not transferable. We have that probably health is more perceived as something related to circumstances, something that individuals cannot do anything about. And therefore, we will expect that health inequality aversion is probably higher than income inequality aversion, okay? However, there is an open question that remains, which is whether or not health is more or less observable than income, and that's an open question that we are going to empirically address. How do we contribute? Basically, our contribution is the following. We use a national representative survey, 1997 to 2024, which is the German SOEP that many of you have used, and that contrasts with all the evidence that has been piled up so far on health inequality and the importance of health aversion, inequality aversion, because the literature so far has been based on experimental design in which individuals are faced with hypothetical questions to elicit health inequality preferences. For example, a lottery on health. Individuals are offered in an experiment a health lottery, and they have to choose between different states, and that's a way to retrieve the health inequality aversion. In our case, we don't do that. We just take the life satisfaction question and we explode the individual's exposure to the local variation on health inequality. Also, what we're doing with this paper is to extend, therefore, the literature that has looked the impact of income inequality on life satisfaction by looking at health inequality. And then as a side contribution that I'll get into details later, we test different measures of health inequality. So we also contribute by examining whether different ways to measure inequality may lead to different outcomes and results. So quick review of the results for those of you who have to leave early or if I don't make it to the end. Basically what we find, as you can imagine, otherwise probably I wouldn't be here, is that health inequality has a negative impact on life satisfaction. And we also find that this inequality aversion, this health inequality aversion, depends on the type of measure that we use. 1% increase on health inequality reduces life satisfaction between 0.11 and 0.949 percentage points. To put it in one concrete example, imagine that we take for each measure, for each of the health inequality measure we use, imagine we take a region that is the lowest inequality and one that shows the highest inequality. Moving from the highest inequality region to the lowest inequality region increases life satisfaction in the same equivalent to 0.138 or as much, depending on the measure, as 0.92. So depending on the measure we use, moving someone within Germany from the lower health inequality region to the high health inequality region is equivalent to 1 point drop in life satisfaction, which, as you can imagine, is a very substantial amount. And these numbers are larger than for income inequality. So income inequality aversion is lower in our data as well as in our other data sets using the same measure. For income inequality is lower than aversion to health inequality. This made us think that probably it is the case that individuals perceive that health inequality is more due to unfair distribution, or people perceive that health is more important, that health is an endowment that we all have the right to have while income is less so, or there is some element that is making people more health inequality averse than income inequality averse. These numbers compare well with experiments, for example, using a lottery on health. Costa, Fon, and Cowell find an inequality aversion is 0.8, which has to be compared to the 0.949 that we find here. So we find very comparable results than those found in the literature. So we go to the measures. I'm going to be very brief because I don't have much time with the time that is given to us. The happiness, I don't have to explain. You are all well familiar. We use life satisfaction question as a proxy for utility, and that will be our dependent variable. And then our measures of inequality, it's one of the contributions actually we do in the literature, because what we do is we measure income, we measure health inequality by means of a self-reported health satisfaction question like this one that we have for life satisfaction, but for health satisfaction. So we take health satisfaction and we measure inequality in each region. I'll tell you how. And then what we also do is we present different sets of measures of inequality. First, we use a cardinal measure of inequality, which is going to be the Gini, the MLD, and the standard deviation. So basically, we assume that answers to the health satisfaction are cardinal and that the numerical values have a meaning. These measures we know that are sensitive to the scale used to measure the health, and therefore that can even lead to a scale reverse in the ordering of the two distributions in different regions. And therefore we also contribute by including two different sets of ordinal measures of inequality. And this is the polarization-like measures and the status-based-like measure. Polarization-like indices, what basically they do is they compute the weighted difference between the proportion of people that are below and above the median of the category distribution in the health satisfaction. So I don't want to spend a lot of time on this, but we can do it in the questions, or we can talk later through email about this. But basically, this measure takes into account how polarized the distribution is by looking at different categories and comparing them with each other. What I can tell you is that this measure goes from 0 when all individuals are in the same category, doesn't matter which one. Say that everybody reports a 0 in health satisfaction, then the polarization is 0, or a 10, the polarization is also a 0. And the maximum number that this variable can take, this index can take, is 1, which is when half of the responses are at 0 and half of the responses are at 10 on the 0-10 scale of health satisfaction. That will be value 1, and that will be when it's more polarized. In our data, this measure takes value 0, 3, 0, 4, depending on which one we use. And the maximum value it can take in our data is 0.6, the minimum is 0.17. So it goes from 0.17 to 0.6, and on average, the value is 0.3, 0.4. And this measure has different options. So here you can see in the alphas and the betas. The alphas and the betas is how much weight we give to the bottom distributions, the ones that is the categories below the median, and beta is how much weight one gives to the top categories. So this measure developed by Naga and Yeltsin allows for different alphas and different betas, and basically the 1-1, so this one, the polarization 1-1, is when we give the same weight to both halves, to the alpha and to the beta, okay? And then we use another type of measure, which is the status-based measure developed by Cowell and Flasher. That's why they're called CF sometimes. And they are status measures, because basically what they do is they accumulate in the cumulative distribution function. They have the cumulative distribution function of everybody, a state. In each category, you have the number or the proportion of people that is there, and then you accumulate the number of the proportion of people that are below on average in each of the category. And then basically what you do is you compare the status average of each by adding each category and dividing, so the average, to the equal distribution, to the equal distribution equal to 1. Okay, and then this again is a parameter that decides, or that is a parameter that what it does is it gives more or less importance to those categories that are farther away or closer away to the maximum status of 1. These measures are defined as downward looking or upward looking. It's two different measures within the same family of the status measures. The downward looking is when you look at the share of individuals whose response categories are lower than the one of the individual, and at the upward is when you do the opposite, okay? So again, I don't want to enter into detail, but just as a summary, when it's 0, it means that all individuals are in the same category, so it's maximum equal. That means, for example, that all individuals report a 10. So everybody is at the highest category. So 1 minus 1 is 0 in the equation, plus some correction for the parameters, but broadly speaking. While the maximum value in comparison with the status, with the polarization measures, is not defined. So this measure goes from 0 to a non-defined number. We don't know what is the maximum number. There is, however, an interesting thing that helps to compare both measures. If you have the polarization index, you have 10 categories. The highest polarization we explain is when everybody's here and half of the people are at the bottom and half of the people are at the top category. That's 1, that's the maximum polarization. You have 50% of the people at 0 and 50% at the 10. While for the case of the status, for example, when everybody is in the same category, so you have a uniform distribution that there is equal number of people in each category, then in this case, this index value is greater than than that for the total polarization distribution. Okay, so basically what it means is that the maximum inequality differs between the rank-based and the polarization-based index. So they are not measuring, they are not translating the distribution of a region to the same inequality index because they focus on different things. Okay, and here you have the summary for if you want to look more carefully when you look at the recording, if you want to. Basically, what we do is we use 26 years of the German data, which is 97 to 2024, which is the last year we had available. And we measure inequality at the NUTS2 region level. Okay, so we have the inequality measures, all these measures I mentioned before. For each of each NUTS2 region, we calculate it from the data. In our baseline result, although we have robustness to the rest, our baseline result only includes those 29 NUTS2 regions that do not coincide with the federal state. We have 9 regions that the NUTS2 and the federal state is the same. So these, for example, cities that are both a NUTS2 and a federal state. Okay, so we drop the coincidence and you'll see why we do that. And that means that we are left with 75% of the sample. So most people, of course, live on those NUTS2 regions that are larger, and there are many of those in one single federal state. Okay, so we have therefore 16 federal states and 38 NUTS, and we only keep those NUTS2 that are not the same as the federal. Now, the identification of the NUTS to health inequality comes from time and regional variation, and we'll enter into detail when I'll show you the equation. But basically, what we need to make sure as well is that there is enough variation in our data, and we are not drawing our conclusions by few observations or in the individual data by few individuals moving, but I'll talk about this later, yeah? So basically what I want to show you now is a graph to make sure that, that we have enough variation both within time and across NUTS, okay? Here, for example, is for the Gini. Each point is 1 NUTS, and you can see that within the, and this is time. So for example, NUTS1, NUTS2, number 1, the first one, goes from 0.2 to minus 0.15. So this is the variation that over time, this is time, over time each NUTS has, okay? And then we also see that there is enough between variation. So we have NUTS that have lower income health, lower health inequality, here, for example, and we have NUTS that have higher health inequality. So we have enough variation both within the NUTS over time and across NUTS. And that holds for all the variables we have here. I show, just for showing, I show the Gini of the health inequality. I show the polarization 1-1 of the health inequality, and I show the status index that has an alpha of, is upwarding and upward looking, and has an alpha of 0.75, okay? Just to show you some of those and to convince you that there is enough variation in our data, and that's what we are exploiting. Also, very briefly only, I want to show you that there is variation in the measures, and that we are measuring different things, and that's why we'll find also different betas for different measures. So basically, if you have the exact same NUT at the exact same year, having the exact same distribution of health satisfaction, the index that we will obtain, the final number that we will obtain indicating the index of health inequality, change depending on which one we are using, because it focuses on different parts of the distribution, okay? So there is here some information on this, but basically this is the correlation. And for example, we can show you that the Gini has the highest correlation. The Gini index has a higher correlation with the status measure than with the polarization measures. Or we can show you that typically, with some exceptions, the measures of polarization correlate with each other, and the measures of a status correlate with each other more than across measures. But in any case, we also show that what we want to show is that the rank correlation between the different measures we are using is, of course, stronger for some than others, but there is also variation, and that's going to be the differences we are going to find in our inequality aversion parameter. This is our initial equation based on Carlson et al. Paper that many people, it has around more than 300 citations, and people that cite it usually it's because they are also estimating the health inequality parameter or any other inequality parameter. Basically, it's the utility function of an individual I living in R in time t. And this utility function depends on, in our case, the health satisfaction of that individual, as well as the inequality that that individual is facing in the region in where that individual lives, and then other control variables that we will describe later. So this looks like a Cobb-Douglas, and the idea is that beta, it's then the health inequality aversion parameters. And that's how it is used in the literature also to estimate the inequality aversion. Beta, therefore, is what is typically used in the literature to estimate the inequality parameter. And as I told you at the beginning, this is typically done by using experimental settings or experimental questions in which people are asked hypothetical questions to elicit these preferences over lottery, and then they estimate this equation using the answers to this experimental setting. While in our case, we use the population data from the German SOEP. Let's take first individual data, which is not going to be our main estimation, but imagine that we take individual data. What we do is we assume that the functional form G of the utility function is linear and additive. We take logs to be able to put everything on linear terms, and then we can transform it by this equation that we can do regression analysis. So basically, we have that the logarithm of the life satisfaction of individual I at region R in time t depends on their health satisfaction as well as in the health inequality of the region where they live. So on health satisfaction and inequality in the region. We add also controls at the regional level. We add, for example, mean income, unemployment rate, as well as income inequality. So we control for those things that change over time. And then we also include individual controls like, their income, education, family status, their health status on top of the health satisfaction. So their own health is included, but we also include whether individual is disabled, number of hospital days, etc. So we include a large set of controls to make sure that we estimate a beta that relates really to the health inequality. We do individual fixed effects. And now I'll talk a second about this. And then we also include fixed effects for time, so year or wave times federal state fixed effects, okay? So this specification, as you can imagine, is very demanding because we do several things. The first thing we do is we include individual fixed effects. That means that we are estimating the impact that the health inequality has on the, so we estimate the impact of health inequality, we estimate inequality aversion by changes that the individual is experiencing from the mean, because we take individual fixed effects. That means that we are exploiting variations at the individual level, and therefore, except for these individuals that move, we are exploiting changes over time only within the same knot. Right? Because if an individual doesn't move, the change in inequality that the individual is experiencing is based on the inequality changes in the region. That means that if individuals were to move around Germany and changes across knots are much higher, across regions are much higher than changes over time, we might be identifying our results only for those individuals that move. This would be an underestimate, but still is something we may worry about, and we will do something about this later. And on top of this, that's why I show you those graphics in which you could see that there was sufficient variation over time, okay? So in that sense, that's very demanding. And it's also very demanding that we include these fixed effects that are shocks that affect the federal state differently each year and each federal state. That means that all the variation that we exploit in the inequality is within the nuts, but we control for the fact that they are on that year in the same federal state. Okay, so we also exploit the health inequality within the same federal state. And I think that's the most important thing I wanted to tell you about that slide. These are the results. These are not our baseline results. These are the individual data results, but you can see that we find very well precisely estimate coefficients. The coefficients are those numbers. I mean, I'm not going to interpret them because our preferred specification is not this one, but we find coefficients that vary in size, of course, but they are very precisely estimated with very small standard errors. So this is not our main specification because since health inequality is observed, important. I did not tell you that, of course, we cluster the standard errors at the NATS 2-year level. So we cluster standard errors. So we also do that. And the standard errors that you see here are the cluster standard errors. Okay, so this is really like fairly cautious regression. Nevertheless, we are exploiting really the NATS2 variation, so we decided that we should collapse our data at the NATS2 year region. So basically what we do is we take the average life satisfaction over individuals that live in region R, the average health satisfaction, of course logs, the average, we take logs of the average, then the inequality, it's not an average because it's the inequality in the region, and we also control for the same things that we did control in the individual regression. We will control for the income in the region, for the health in the region, for the unemployment rate in the region, and then later on we will include even more things like the age structure and all those things that may be influencing as well health inequality. Okay, so we collapse our data and we end up with 28 times 24 years, so 754 observations only that are the averages of everything except for inequality, that is the health inequality. We also control for the interaction term between federal and year fixed effects. So again, this keeps being a very demanding specification in which all the variation that we are exploiting is the inequality, health inequality change in the regions, okay? Controlling for the fact that this is controlled for. Now, beta measures here the elasticity, as we were saying, the health elasticity, inequality elasticity, and that means basically that it is the percentage change in life satisfaction that results from a 1% change in the health inequality measure, okay? About the endogenous sorting, I don't want to spend a lot of time on this, but imagine that individuals some individuals would care a lot about health inequality and others would not care at all. Then individuals would freely move around Germany, and that would be their optimal, I mean, they would be very much focused on health inequality. Then we will see that there are, or anything that correlates with health inequality, of course, then we would see that those individuals that care more about health inequality would move to places where there is no health inequality. So people would sort into places where there is less health inequality if they care a lot about that, okay? We are not worried a lot about this because moving within Germany, at least in our data set, is very small. We do not observe people moving across NUTS2 regions. We observe a very small percentage of movements, but imagine that this would happen. Then we are still confident that, one, we are taking averages, is our collapse data. So it means that a lot of people will have to be moving so that our average life satisfaction at the NUTS2 region is impacted. And then on top of this, if this would be the case, then what we are finding will be a lower bound estimate, because only people that care move to lower inequality regions. So we would be observing in high inequality regions those individuals that don't care about it. Okay. Now, I know I don't have much time, but nevertheless, I hope I have you more or less convinced that we do a lot of the things we can to make sure that the estimate we find is as close to causal is not, but as close to real effect as possible. And I can now show you the results. Oops. Here it is. So let me show you the table. I don't see the table myself. Let me show you the table. I don't know how to do that well, it doesn't matter. I don't see the table. I don't know why. Here it is. So basically what you can see here is that, again, we find except for this one, the rest are extremely precisely estimated. We have very small standard errors. So that we can assess that the coefficient we estimate is very precisely estimated. For the cardinal measures, which are these two here, we find a 0.17 estimate. I'm gonna later tell you more on the conclusions what that means. Then for the status-based measure, which are those ones here, what we can say is that they range between 0.59 and 0.95. This should be compared to the 0.8 number that it's found in the experimental literature. We find no significant differences between downward and upward looking, but it is true that we find that the measures increase the more weight we give to the upper part of the to the upper part of the distribution, or to the categories, or to the upper part, or to the categories that are higher to the upper categories. Okay, so in a way we can argue that the inequality aversion increases as more weight is given to the upper part. Okay, 0, half, 75%. And then finally, about the polarization measures, the point estimates are lower than those for the status measures, and they are around 0.6, 0.1. Okay. Of course, is what I was telling, and I'm about to finish now. I was saying that, you know, we have to control for many other things, because even if we control for federal time fixed state, there might be things that there could be other things that happen at the nodes 2 level, and they are not shared by the federal state. To control for this, what we do is, on top of the health inequality, we introduce in our regression time-changing averages, time-changing characteristics of the region. For example, we include income and unemployment rate. Imagine that richer regions have better, they are richer, they also have better health, they have lower health inequality. So then maybe what could be happening is that we are not capturing the health inequality aversion of the individuals, but we are capturing the inequality or the income poverty aversion of the individuals. So despite we do control for federal and year interaction between 5 years fixed effects, we also include that. So for example, in these tables, we see that nothing changes, and when we include the income inequality, that is negative. When we include the income, the average household equivalent income of the region, which is positive, the richer the region is, the happier the individuals are. The more income inequality there is, the less happy individuals are, and the median health satisfaction of the region. The more health satisfied, the higher the median of the health satisfaction of the region, the more individuals satisfied are, but the rest of the coefficients for our health inequality remains the same. We can say the same about the polarization measures. They remain the same even if we control for all those region characteristics at the same level, at the NUTS 2 level. There are also other potential confounders what can think about, for example, unemployment rate, average years of education, and even age structure. So we even control for the average age of the region, and in another we control for population structure every 2 years. So we introduce age groups, how many population 0 to 10, 10 to 20, 20 to 30, etc. lives in that region, because of course age is very much correlated to the health of the individuals, of the population. So here we control for age, unemployment rate, education, as well as the same variables as before. And again, introducing all these controls don't change anything or change very little of our estimates, both for the status, for the inequality, for the status measures of health, and for the polarization measures of health. It is true that we lose significance here, but this was already the smaller coefficient. For the rest, we don't lose any precision on the estimates. So basically, I think we are very confident ourselves. We do also robustness to other things. And basically, we are very confident that we can estimate the inequality aversion. And that we do that by using the life satisfaction measure that avoids framing and avoids hypothetical scenarios. It's a representative sample. We explode the health inequality that individuals are exposed to. We don't ask them. We don't know how much they perceive of it. We just take it as granted that this is what they perceive. And we think and we argue that since our inequality aversion for health is much larger than our income inequality aversion, and it survives unemployment rate and other measures of economic stress, economic uncertainty in the region, we therefore argue that we believe that individuals think that health is beyond individuals' control, and that therefore they care a lot about health inequality because they think it's an illegitimate inequality. And then just as a summary, remember that what we found is coefficients that are between 0.59 and 0.95. These for the status measures, smaller for the polarization measures, but these coefficients are in line with the literature that uses experiments. And then just as a wrap up, this 0.95 implies again that moving from the lowest to the highest inequality region, individuals change 1 point in the income in the life satisfaction. So for our stronger estimate, that's true, but for our stronger estimate, for the measure that is more able to capture the health inequality that individuals care about, we find that moving from one region to another region within Germany, we are not changing countries, within Germany is strong enough to move life satisfaction by 1 point. And the lowest estimate is 0.138, which is also not a minor effect. And that's it.
Ada, thank you very much for this great presentation. We are now going to move to the Q&A sessions. So if please you can all turn your camera on if you want to ask any question directly to Ada. I will start, Ada, by asking you, what do you think are the policy implications of these results? Maybe at the local, at the regional, at the state level, and how do you think that, okay, here we are talking about Germany, how this could translate maybe also in other contexts less economically developed? If you can maybe give us your insights and your opinion. Mm-hmm. Thank you, Ada.
You're welcome. So thank you very much. The thing is that I think that it's we know from the life satisfaction literature that the context is very important. And we also know that people really care a lot about tensions, social tensions, uncertainties, inequalities, polarizations. And I think that it's very important that policymakers put a focus on this if we are to increase the well-being of society, which I think should be per se is a very noble objective, right? And we also see that in when we look at papers that look at economic growth, for example, like economic growth increases life satisfaction a little, but economic downtowns really decreases life satisfaction a lot. And I think we have to make an effort to redistribute not only income, but also all the other dimensions of well-being determinants so that we all can have a higher level of well-being. And then another thing that I think it's interesting is that this health inequality that has been in experimental settings examined here is we can examine this in real exposure, right? People are exposed to this, and we see that health inequality survives like income inequality, unemployment inequality, and many other type of economic. And that, to me, it probably means what I was saying, right? That people really think that health is something that is the outcome of unfair result more than income, although income too. And I think that there is probably a large set of a large group of people that think that income inequalities are partly the outcome of a fair process, and that's probably not the case. That's my vision, that it's probably not the case, and therefore that a lot of political education should be done also so that we are all conscious about how important it is the circumstances of every person. Like we know from health, it goes to income as well. So if you don't have the same situation, not only socioeconomic, but also health, etc., it's much harder. It's much harder for some people to make a better income and a higher income, and that and then people would care more because they show that in the health inequality.
Totally. Thank you, Ada. Before we move to Francesco, I think that there was a question in the chat by Khadija. Khadija, if you can turn your camera on and ask Ada directly. Khadija, I don't know if you're here. Well, we will. Khadija was asking if the mediation effects potentially exist. I don't know exactly what, if she could develop a bit more. Well, if later, Khadija, you can turn your camera on and explain better the question, it will be great. Meanwhile, we're going to move to Francesco. Francesco, if you can turn your camera on and ask Ada.
Okay.
Hi, Roger. Hi, Ada. I'd love to turn my camera on, but somehow the computer decided that...
Okay. We know you, so we can see your face even if you don't turn your camera.
Just imagine me. Thanks a lot, Ada. Fantastic presentation. I have basically one curiosity and one question. So the curiosity is, have you checked if health inequality aversion increases over time? As you have, like, increases over time. So you could estimate, for instance, this parameter over intervals of, I don't know, 5 years, and then check if over time this health inequality aversion has attracted the systematically larger or smaller coefficients. I think it would be an interesting dimension to the problem you're raising. And the other thing that the question I had is, thinking that you have individual level data and considering your experience on, working at individual level with this data, my first hunch would have been to use some measure of health comparisons. So kind of estimating some social comparison group and then evaluating the health of that group and see how that kind of, let's say, average health comparison affects the individual satisfaction. Have you considered this? And if so, would you say this could work, or why this wouldn't work? I would be curious to hear your opinion on this approach.
Thank you, Francesco.
Thank you.
So the first thing, great. I wrote it down. It's a good point. You get to take time intervals and see if there has been some change. So I'll look into it. And then with the individual data, the thing is that I think I should change my mind, because my co-authors pushed me more for the individual data, and I was a bit agnostic, and that's why I collapsed the data from the very beginning. But that limits a lot what you can do, because rank is something that is only defined at the individual level, as you well said in your question. And then first we thought we should look at rank, but then, rank doesn't exist for the collapse data, and we didn't look at it anymore. Then there was also the idea of using maybe risk aversion parameters and locus of control, and this is all defined at the individual level. And, I was so obsessed with the collapse, but after this question, I think that I should go back to listen to my co-authors, and at least, because they wanted to do the individual, the main, and the collapse, the robustness check, right?
Mm-hmm.
And maybe I could do that. It's not that difficult now that we have everything. And that would be interesting to look at the rank. And then we could also do what I was saying, to use the risk and the locus of control and all those things to see whether we can exploit some mechanisms as well on that. So yeah, thank you. You convinced me, I guess.
Thank you very much.
Khadija.
Yeah. First of all, Ada, I want to congratulate you for such a elaborative and very well explained presentation. But I was a little bit wondering because have you ever potentially checked for mediation effects, like maybe somehow the health inequality is going to mediate potentially the relationship between life satisfaction and income inequality. So that could be a potential mediation effect, which I intuitively I can sense it from the relationship which you were first introducing in the first slides. So I would expect somehow there may be some mediation, but have you checked for that? How much percentage, or whether if it exists or not at all, something like that.
So thank you for your comment. So the thing is that once it is, health inequality and income inequality, one would think they are correlated, right? Because health is one of the main, well, not one of the main, but it's an important determinant of income, and the causality runs this way. So what we see is that when we only include income inequality, it has quite a strong effect on the life satisfaction. Once we put health satisfaction, what survives, like if you do a horse race, what really survives, income inequality reduces its size, and really what survives is health inequality. So I think that, but it's not clear that this is mediation, or whether this is just that these two measures are correlated, but that people think that health inequality is less fair, and that should be addressed, right? That it's more illegitimate thing. Another thing we could do, maybe now that you say that, is to try to examine more careful the data and look at the correlations that we find at the regional level between all the economic inequalities, not only the Gini, because the Gini and the standard deviation of these things, it's very sensitive to small changes, but we could look also to unemployment rate and all these other variables we have, and see how much they correlate with health inequality, for example, and do kind of descriptive analysis, or I have to think a bit more about it. Out of the here, I cannot have a better idea, but something that,
it triggers mind. Maybe there are some overlapping things, or maybe they are like one way, or indirect or direct effects may exist between the two.
Yeah, exactly. So we can do it by the regression, but we could also look at the descriptives first and discuss more in detail, and then move to the regression analysis. But health inequality survives all the other variables. It's stronger than the other variables. Like unemployment rate is also something that is very strong and survives a lot. The rest. One thing that we were also thinking maybe is to add something like poverty in health, like below certain level. And then put kind of a percentage of people below the median health or something like this, but that's something else.
Yeah, and somehow some quintile regressions, to run different regression for different quintile population.
Okay.
Anyways,
Thank you. Thank you, Khadija. We have now time for one last question. Christy, maybe you can turn on your camera and ask Ada directly. Yeah, thank you.
Hi, everyone. I'm brand new to the society, and this is my first webinar. So thank you so much for being so welcoming and inviting. Thank you for a wonderful presentation. As a doctoral student, no lie, some of it was over my head. But I'm wondering if correct me if I'm wrong, but I believe Germany has a form of universal healthcare. Yeah. And so I'm wondering if there would be an opportunity to kind of assess how these variables might work in the US. For example, we're just about to experience honestly a devastating cut to a lot of our healthcare. And so I wonder if kind of assessing these variables in a place that doesn't have a universal healthcare could kind of help us strengthen the argument for universal healthcare. I don't know. What are your
It's
thoughts?
actually very interesting for several reasons. So in income inequality, for example, like you always find that the impact of income inequality on life satisfaction is higher in Europe than in the US. And it is higher because people feel that the outcome, so people feel that the income distribution in the US is the outcome of a fair process. So many people think in the US that they live in a meritocratic society, whether if you put effort, you get a higher income. Now, the measures of equal opportunity that we have, that probably they are not that well, no one can hear me here, but probably they are not the best in the world because it's very hard to measure, right? But the measures we have, the best measures we have, they tell us the opposite, that there is more equal opportunities in Sweden than in the US. So that would be a very interesting concept because since in the US, everybody is aware that there is no universal coverage. However, they are aware that there is in Europe, so they know that there is another possible world, and they know they live in a world where there is not. I wonder whether in here we do find these differences also, and that's something that we should look at, because maybe this is a good comparison to compare the income inequality aversion in the US. We know is lower than in the Europe. What would happen with health when it's explicit and known by everyone that that it's worse opportunities in the US? So that's a good point. I don't know, but I think we have to do it.
Thank you, Christy. And we are now arriving to the end of our webinar. So thank you everyone for participating in Ada's webinar. Gracias, Ada. Please be sure to participate in all of the ISQOLS webinar sessions and to follow us also in Instagram. We will be posting this recording and all the other session recordings in our ISQOLS platform soon. Thank you, Dr. Ferrer-i-Carbonell, and everyone that participated. See you in the annual conference this year in Kentucky, in the US. So thank you. Adeu. Bye. Adios. Arrivederci. Gracias, Ada.
And for those of you who don't know, I'm so old that Roger used to be my master student. Yeah. Imagine if I'm old. Thank you so much, everyone, really.
Thank you so much.
Gracias, Ada. Gracias.
Bye-bye.
So.